Our next presentation is Pharmacy for Fall Prevention. And we have Marianne Spence and Kate, I couldn't see you up there, presenting today. So Marianne Spence, first of all, is a registered nurse with experience in leadership and education across a variety of settings in both New Zealand and Australia. And her current role is Director of Aged Disability and Palliative Division. So a new expansion to that role. So well done for that. Kate Grogan is a clinical pharmacist with our virtual clinical pharmacy service within our LHD. Kate, she has a keen interest in improving pharmacy involvement in falls management across the district. I first came across Kate when I was a clinical physio, and we implemented using virtual pharmacy in our patient-centred bedside ward rounds once a week, and it's just made such a difference to our care, and you're continuing that, and now you've presented a couple of times for us about pharmacy. So really it's how much medications can contribute significantly to a first person's fall risks, and this presentation explores the impact of medications on the falls risk and what can be done in the falls prevention thing. And I will say, I think it's something that's really under-recognised, and obviously it's your bread and butter, but when we do an adult admission assessment or we do a RAC admission assessment, the medication section is not mandatory to complete. And I think it's something that is missed significantly across our district, what effect our polypharmacy and our high-risk medications are having on our older people and how much risk that increases. Anyway, I'll stop talking and let you go. Thank you.
Hi everyone, and hi Kate. I've not seen Kate in person before. We look like a team, but we've never actually seen each other. And when you see someone in 3 dimensions, you just want to touch them because you've only seen them through a screen. I'm conscious that we're between you and lunch, so I'm feeling the pressure a little bit. Today we just wanted to talk a little bit, and I've heard some conversations about the standards that guide our management around falls. I want to pull out a couple of clinical care standards and just talk about why they matter in falls prevention. And then Kate will talk about how medications contribute to falls risk, some of the high-risk medications. We'll touch briefly on medications for bone health. And then if we get time, we'll talk about the effect of ageing on medications, and Kate will talk about how pharmacists can help. So there's a whole lot of standards that are involved, and when we think about falls prevention, we can think about the clinical governance standard, or the things that we put in as an organisation to help improve safety and the quality of care that people get. We can think about how we partner with consumers, how we work with consumers to talk about their risk of falls and how we can keep them safe. I think about my work with my mum. She now doesn't wear slip-on slippers anymore. She wears shoes that go over her feet, and I've removed the rugs in her laundry, much to her chagrin, but it was a plastic rug on a slippery floor, and it was a 90-year-old fall risk waiting to happen. So how we partner with consumers and their families to make a difference. Then there's medication safety, which is what we're going to be talking about today. But there's other things like the comprehensive care standard, how we deliver care to someone in a comprehensive way. That's about the behaviour support plans that we were talking about earlier, but the way we connect with the person and individualise the care to the client that we're delivering care to, how we communicate for safety with the client and with our colleagues, and then recognising and responding to acute deterioration, which is what I want to talk about next. There's a couple of clinical care standards that I want to pull out today, and the first one is the delirium clinical care standard. So as a district, we've got a guideline around how we manage delirium, and from an aged care lens looking in, sometimes we do it well and sometimes we really miss the boat. And within that delirium clinical care standard, there's a number of quality statements. There's a focus on identifying people who might be at risk, how we put in strategies to prevent the risk of delirium, thinking about how we provide information to the patient and to their family. And it's not good when your family is a good example, but when my 89-year-old mother was in hospital last year and she said, oh, and my family rang and said, there's something really wrong with mum. And I said, I sent the ACI brochure. She's got delirium. Here's what you need to do. When you visit, you've got to push food and fluids, et cetera, et cetera. And then I talked to mum and said, Mum, you've got delirium. So getting family involved, naming it, helping family know what's going on, that's really important in terms of our delirium clinical care. But number 7 on this list is avoiding the use of antipsychotic medication. And that is something that I really like to talk about today. I think that, and Stephen, great presentation about evidence. The thing is, there is no evidence supporting the use of antipsychotic medication in delirium. But there is very strong evidence for the risk of harm. So there's a risk of oversedation. There's a risk that then if you're oversedated, you're not going to drink so well, which increases the risk of falls. Medicines on their own increase the risk of falls. So there's a whole lot of complications that happen when we give people antipsychotic medication or psychotropic medication in delirium. I haven't seen the research, but it's my sense that you actually prolong the delirium journey. And I'm not sure whether any of you have tried psychotropic medication, but if you've already got a cognitive insult, to add another cognitive insult, which is a medication that changes your thinking, on top of an existing cognitive insult, it's really hard to get your sense of reality back into play again. So I guess the message I like to say is that managing delirium with psychotropic medication is not the best. Choosing Wisely, and this is 2016, as part of their focus, the recommendation was in particular not to give benzodiazepines as a first-line management in people that are struggling with insomnia, but also in people with delirium. But also in the top of this, and I'm sorry, it's a little bit fuzzy for you to read, but the other piece of advice from Choosing Wisely is do not use antipsychotics as a first-line treatment in the management of people with the behavioural and psychological symptoms of dementia. And the second clinical care standard, and this is like an advance notice that's about to come out in May, is a new standard which is focused on psychotropic medication and cognitive disability, cognitive impairment. And so it's a new standard. It's actually a collaboration between the Age Quality, Safety and Commission, the Health Safety and Quality Commission, and the NDIS to look at some governance around how we manage psychotropic medication. As an LHD, I know we do lots of things, but primarily our bed base is care of older people. We've got a lot of people in our MPSs, and 65% of the people in our acute beds are over 65. So we're in the business of providing care to older people, and older people are more at risk. The biggest risk factor for dementia is being old. So we will see people in our hospitals with dementia. We also see people in our residential aged care facilities with dementia. And using some information from the Australian Commission on Safety and Quality in Healthcare, we are using too many antipsychotics to manage BPSD in our older people. This evidence suggests that 1 in 5 people in our residential aged care facilities are on antipsychotic medication. And for the people prescribed antipsychotic medication for BPSD, only 1 out of 5 people who are prescribed it will actually get any benefit from it. But there is a huge risk of harm, and the risk is falls, stroke, death. So it's not great as a first-line management, and I haven't got time to talk about what other options we've got, but medicines aren't the first choice. They shouldn't be the first thing we reach for. In actual fact, risperidone is the only drug on the PBS for BPSD, and it's very narrow. 12-week prescription for people with Alzheimer's-related dementia with psychosis and aggression. Narrow, narrow, narrow. But we're not seeing it for that indication, and we're seeing people with prolonged prescriptions. So my take-home message, delirium and dementia, try and avoid the psychotropic medication because falls risk just goes up hugely.
All right, so I'm just going to talk about the medications and how it can increase your falls risk. So we know that taking more than 4 medications is common among the elderly, and although it can be therapeutic in nature, it is linked to adverse events such as falls. And there is a strong link between older patients falling and the number of medications prescribed that increase their falls risk. And taking multiple medications is associated with a falls risk, and as a result of adverse reactions to one or more of those medications, drug interactions, or incorrect use of all of these medications, we can have these medications that can cause drowsiness, dizziness, poor balance, changes to eyesight, diuresis, and extrapyramidal side effects. So what medications are we looking out for? So some of these medications can increase a person's falls risk, and these include antihypertensives, diuretics, psychotropics, sedatives, and opioids, among a few. So I just wanted to touch on 2 in particular that we're most concerned about. Firstly, benzodiazepines. So these can cause harm by increasing a person's falls risk. We know that tolerance develops quickly, normally within 3 days. And particularly in the elderly, we're concerned with the metabolism of an older person and how it decreases, which would cause the drug to accumulate in the body. So we're particularly concerned about the sedation, dependence, confusion, memory impairment, and incontinence. And the falls risks associated with benzodiazepines are not only from the sedation side effects, but also the withdrawal. So withdrawal can be difficult when we're trying to stop it in this age group. And it's important not to stop these medications abruptly. There needs to be a tapering dose plan, and ideally it's best to never start. So the reason that we're so concerned with stopping abruptly in people that are dependent is that it can produce these withdrawal side effects. And this can include anxiety, insomnia, nightmares, hallucinations, which are obviously very uncomfortable for this group of patients. And it's always best to involve pharmacy if we're trying to come up with a dose reduction plan. So I just wanted to show this graph and table that demonstrates the effect of benzodiazepines on sleep time. And it shows that the mean increase in sleep time is only 25 minutes per night. So we just really have to consider, is it worth the potential side effects and adverse effects from this medication versus the potential increase in sleep time? And I hope you would all say, no, let's just not do that. Come up with some non-medicated options. So psychotropics. So I just wanted to touch on some statistics on psychotropics. So we know that SSRIs and opioids more than double the risk of a hip fracture. There can be a 66% reduction in falls through the removal of psychotropic medications. And this is something that we see all the time when we come up with plans to take these patients off medications where it's not therapeutically indicated. There's a significant risk of adverse effects from psychotropic medications, such as psychomotor effects, drowsiness, confusion, and anticholinergic effects. And it can be difficult to seize these medications because they can obviously be prescribed for a good reason. So it's important that we're really looking at the indication for these medications, and if it's a clear indication and they need to be on these medications, or if it was prescribed temporarily for delirium and is just continued on, unfortunately. So these are the adverse effects that we want to particularly look out for. And they're associated with the use of antipsychotics, which are extrapyramidal side effects, or EPSEs, and they're caused by the blockade of dopamine. There's 4 categories to look out for. So these are pseudo-Parkinsonism, acute dystonia, akathisia, and tardive dyskinesia. So if you notice your patients experiencing side effects like this, it's really important to notify the medical team and pharmacy to come up with a plan as to how to manage it. So I just wanted to touch on medications for bone health. So patients increased risk of vitamin D deficiency should have levels taken before they're started on vitamin D supplementation. And these are, this patient group is often seen in our residential aged care facilities and long-term hospital admissions. We know that supplemental vitamin D improves neuromuscular and psychomotor performance for older people, and it has also been associated to show a prevention of falls and fractures in this age group. So if the therapeutic guidelines suggest that if a resident is found to be deficient in vitamin D, it's not necessary to repeat levels and just plan to continue supplementation ongoing, because it's unlikely there's going to be a change in their environmental factors that would cause their vitamin D to be normal without supplementation. So with calcium supplementation, it should really only be required if we know that a person's calcium, daily calcium requirements can't be met through dietary intake. And once a patient is commenced on calcium supplementation, the level should only be repeated after 3 months. And for osteoporosis management, it's really important that we have sufficient levels of calcium and vitamin D levels before we start them on any medication. And I also just wanted to point out the osteoporosis management and fracture prevention in postmenopausal women and men aged over 50 years. That has some really good guidelines on how to manage osteoporosis in this age group. So how are we going time-wise? I might just quickly cover the effect of aging on medications. So with the brain, we know that as we age, the blood-brain barrier becomes more permeable, and the effects of various micro and macro traumas have occurred. So micro traumas can even include things like hypertension, and the elderly become more sensitive to centrally acting agents because they're able to permeate the blood-brain barrier better. So there's a reduction in cholinergic neurotransmitter activity, and it means that they're more sensitive to anticholinergic side effects of medications. With the liver, there's a reduction in hepatic blood flow, which can be about 40% less later in life. So this causes a decrease in first-pass metabolism and a reduction in albumin production, and this can affect the free concentration of drugs in the body. With the muscles, so no matter how fit or active you are, there is a loss in lean muscle mass and an increase in adipose tissue. So any drugs that are lipophilic have a longer volume of distribution and a longer half-life, meaning they stay in the body for longer. With the bowels, there's a reduction in the transit time of bowel contents as we age. So drugs with a constipating side effect are often exacerbated. With the kidneys, there's a reduction in the mass of kidneys and reduced renal blood flow, which means that renally excreted drugs are cleared more slowly. And finally, with the heart, the natural apoptosis of cells in your heart can lead to conduction abnormalities, and drugs that can affect conduction may then have unwanted side effects. So basically, overall, we can see that elderly people have a high sensitivity to intended and unintended drug effects at lower doses. So how can pharmacists help? So we love doing medication reviews of your patients, and this could be organised by nursing staff, medical staff, and we really like to review their current medications, minimise the use of medications known to increase their falls risk, consider alternative medications and treatments, and look at ways that we can reduce risks such as postural hypertension from cardiac medications. We're also a great resource for patients and carers in providing information on current medications. As Ash mentioned, we really want to be more involved in contributing to falls huddles. So please log a consult on the census task list for a pharmacy review. You can do that no matter what site you're at. And we're always more than happy to help. And that's all that I had today. Thanks, Ash.
Thanks, Ish.
Thanks, Kate and Marianne. That was great. And lots of food for thought and lots of referrals coming your way. So if everyone can take home some of those messages, that would be fabulous.